Good morning or good afternoon, depending on your time zone. Welcome and thanks for joining us for today's HIStalk webinar entitled Advancement in Clinical Efficiency Through Aware Computing, and it's supported by Aventura. I'm Lori from HIStalk and I'll be moderating. We have two presenters today. First up will be John Gobron. John is President and Chief Executive Officer at Aventura. Joining John today will be Scott Raymond. Scott is the Executive Director of Information Services at MemorialCare Health System. With that, I'll turn it over to you, John.
Thanks a lot, Lori. Appreciate the introduction. I'd like to say thanks to Scott for joining us, and would really like to say thanks to everyone in our cyberspace audience. I'm doing this phone call and webinar from my office in Boston, Massachusetts, and I'm looking out at a pretty good snowfall right now. I realize that most of the east coast of the United States is socked under snow and ice. So for those of you who could make it today, I really appreciate it. And for those who can't, hopefully you get a chance to listen in on a recording. So as I was preparing for this webinar, I like to put myself in the shoes of an audience and say, well, what questions might I have when I come to this? And one of the questions that I would definitely have if I was joining this is what is awareness, and how do you define it? So I thought I'd start with that, and hopefully I'll answer a lot of other questions for you as we go forward. So when you think of awareness in outside of healthcare, you think of things like a smartphone, or things that right now they're going into cars. The smart home is going in. The internet is probably the most aware thing that exists in computing right now. And the concept of awareness means that you can take different inputs and different elements and use it to make decisions. When we think of awareness in clinical computing, we think of right now what we can deliver is the concept of user awareness, or patient awareness, location awareness, device awareness. One of my favorite things that I do at Aventura is when I have conversations about this, I like to ask CIOs or physicians or really anyone that will listen, what else can we be aware of? And I really like to hear people's opinions on where we should be taking this new concept. One of the things that we definitely are not hearing a lot of awareness is computing. We go to actually, if you could go back a slide, Catherine. We think about what kind of is unaware. And computing historically has been a really unaware technology. Computers in themselves can take information and help process it. But when you think about it from an enterprise perspective, you look at healthcare is often called very siloed, and you think of the traditional clinical application living on a desktop often thinks of itself and is developed and deployed as the center of its own universe. So historically, an EMR might only function from an EMR perspective, and a PACS system might only function from a PACS perspective, and other applications. And while they can historically share data, the usability of them is often fractured. And really, when we think of it, we think that we try to bring awareness into this is the desktop is really the center of the clinical computing universe. The patient really is the center of the care universe. But I like to think of the desktop as when the physicians and nurses are using these things, how can you bring it together? And we think of what would happen if we can bring awareness to an enterprise computing experience. What would happen? So we think about, as I mentioned, we can bring device awareness in today. We can bring in patient awareness today. We can bring in user awareness. And these are things that if you speak with a physician or a nurse or really anyone that uses a computer, it's almost intuitive. Why can't it do this? It's something we hear a lot. Why can't it know who I am automatically? Why can't it know what patient I'm seeing automatically? There's enough information in the overall system to be able to do these things. Why can't it know that I want to go back and forth between a desktop and a tablet, or my PC-based EHR and my tablet-based EHR app? I want to go back and forth, and I don't want to have to tell it what to do. I just want it to do it. So we hear that quite a bit, and ultimately, the computer does bring a lot of value in helping provide care. but the use of it is a pain in the neck. And really, when we think about delivering an aware desktop, we talk about faster access and spending more time with patients. It's really so doctors can get right to work and nurses can get right to work. And then think of, how does it work? We don't have anything prepared on the technical architecture, and I don't think that's why people join today. But I really think about this firstly from a user's perspective. And when you think about awareness computing and clinical computing, everything initiates with getting onto the thing in the first place, getting onto a computer. And the strong authentication has really taken hold in healthcare, and it's, we provide a variety of ways to do that. Most common is the tap of a badge. Most hospital employees and contractors and doctors and nurses have an ID badge to get into their place of work. And that's a really good thing. It's, when you think about multi-factor authentication, it's usually something which is your name or your password, and something you have, which is your badge. Something you are is the third factor. And those have historically been really difficult to implement into healthcare because of the corner cases in biometrics or fingerprint biometrics, irises. There's always enough things that don't work to prevent it from enterprise-wide adoption. So the default has been the badge, but we continue to see lots of interesting tries at the biometrics, and hopefully one day one might have this enterprise-ness that the badge has. But for the most part, you log on and you get to your desktop, you get to your applications, and that's the first step. But then we start thinking about workflow. And one of the things that we try to replicate, you talk to a lot of physicians, and they liked the day when they had a paper chart. You hear a lot about EMRs, and they talk about their chart, and they're replicating a paper process in a computerized form. And when they have the chart, they can walk around with it. And we think the same thing should be capable in computing, and we're a big proponent of roaming. So that once you have your desktop set up, you should just be able to bring it around with you. And it can be, as you move, as you take advantage of the mobile nature of healthcare, the desktop should be able to mold to where you are and who you are and who you're in front of and what you're using. And again, that goes back to the concept of awareness. So we like to think of, of bringing this machine around or bringing yourself around and having that desktop just kind of automatically appear in front of you when you retap your badge, have it happen in seconds. And you think about the next step is awareness updates. As I mentioned, when you go to a new location, things might change. Things might not change, and that's okay, but then you might be in front of a new patient. You might want to do something different. You might want to continue your notes from the last patient. You might want to go to a different device. And, that's all what we call awareness updates. So as we move to the left side of this image, we think about frustrations being alleviated. I don't think that we or anyone else is really going to end clinical frustration with computers. That's probably too big of an ask in at least my lifetime. But we can work towards it, and that's kind of what we go to. And, ultimately, there's a lot at stake with respect to supporting other healthcare initiatives, with things about coming down the pike like analytics and things that truly begin to impact care at both the patient level, but also at the systematic level. Population health and all these things that are right on our horizon, they all depend on the person using the computer in the first place. So, ultimately, when I think of how does it work, I'm really talking about clinical computing and the benefits that awareness computing bring. I'm happy to get offline with anyone that's interested and talk about the architecture of how we do it, because we do some really unique things from an architectural perspective that really nobody else does, and I find that to be very exciting. I think about what does this really mean when we think about impact, and what do our customers say? And Scott's going to talk about that a little bit. And I'm not really going to read any of the slides here, not to bore you, but from what we hear from customers that have adopted this technology, the solution, is it's largely about time. We provide time back to a physician. We enable them to, as we like to say, practice at the top of their license, to be as efficient as possible, to impact the quality of care, and also the quality of life, both for the patients as well as the caregivers. You hear so much about people, nurses and doctors, that stay after their shift, sometimes for hours, to do their clinical documentation, when we really want to be able to help them do it at the bedside. I have a colleague whose wife is a nurse, and she does bedside charting, but her version of bedside charting is she does charting when she's home in bed on her laptop. which just isn't optimal for a lot of reasons. As we segue over to how this helps the enterprise, and you talk about doctors and using EMRs and initiating the data build, the concept of what we're trying to do in our health system, things like meaningful use and some other government and healthcare specific initiatives are tremendously beneficial when you think about helping the healthcare ecosystem. And most everyone benefits. Patients definitely benefit, health systems, payers, research. But as it stands now, or maybe as it stood yesterday, people that use the systems, the doctors and nurses, their lives are a little harder when you go from having to do everything on a computer. The logistics are a little challenging. It's hard to maintain eye contact when you're treating a patient and having to type at the same time. So anything that we can do as an industry and as a company and as a platform to take away that time in front of the computer and add to time in front of the patient is really what we see where we bring a lot of benefit. So the things that we hear when we go out and talk to people like yourselves and CIOs and doctors and healthcare IT people is the initiatives that they want to see solved are around this, and primarily again around speed and workflow. Make it easy to use the computer, as intuitive as possible, and good things happen. And if you think of this, starting in the top left and segueing over, if you use the computer, you support this initiative. A lot of hospitals are getting a lot of money for these meaningful use reimbursement, and if you don't, if the physicians and nurses aren't using it in the way that's prescribed, they're going to lose out on some money, and really they're not going to give care to the degree they want to. The other element of that, though, is security, and there's a really high security requirement for the use of the computers and the protection of the data. And we have a saying at Aventura, the cost of putting PHI in an endpoint is too great to ever consider doing it. And with virtualization, the data never gets there. So you can't have a breach on a device if there's no data on it. So we're big proponents of virtualizing applications and virtualizing desktops, not just because it's super fast and not just because it's easier from an IT perspective and a clinical workflow perspective, but it's also super secure. So when you think about all that's at stake, not only are we all professionals in this healthcare IT world, but most of us are patients at one point or another. And the concept of my healthcare information getting out into the wild is not something that I really want to entertain, and I don't think anyone else does either. So we like to think of this as a big part of the value that awareness computing brings to healthcare organizations. And then lastly, right now there's a tremendous amount of change going on in our industry from a reimbursement perspective, from an organizational structure perspective, and a lot of that is around cost. As a country, we spend an inordinate amount of money on providing health care, and anything we can do to lower that cost but maintain the high quality of care is a good thing. And you hear a lot, well, because of the reimbursement changes, because of this, because of that, our budgets are being cut by 5%, 10%, 20%. We have to deliver better care with less money. So we really feel like our story of improving access to the computers at the start of the whole entire process, making that faster, making that more efficient, is a really good way to start. It helps with your staffing and eliminating wasted time and improving the amount of patients that can be seen from a physician perspective. So we really feel like these are the things that we hear when I call it healthcare initiatives. These are the things that our customers and our prospective customers and people, when we meet them at HIMSS and other industry shows, these are generally the top of what's on what we like to call the priority of whiteboard of priorities. I mean, but I think that's kind of nice maybe to hear me talk about it from an awareness computing perspective. But I'd really like to pass the baton over to Scott Raymond and let him talk about awareness computing from an actual implemented solution perspective. So I'll pass it over to you, Scott.
Thanks, John. I'd like to empathize about your weather, but out here in Southern California, it's like 75 degrees.
Yeah,
and clear.
I can see that for that one.
I'm not sure we're going to get a winter this year, so.
I'll send you a picture.
Anyway, all right. Well, thanks. Appreciate everyone logging in to listen to what we have to say. I think it's an interesting story, and I think it's a compelling story. So who we are, so we're a six hospital system out in Southern California, so we span from kind of the Long Beach, LA County area all the way down to San Clemente, which is close to San Diego. We have 6 hospitals, like I said. We have a medical foundation with about 300 employed physicians. We also have an IPA, and we're kind of getting into an ACO realm with providing freestanding ambulatory surgery centers and radiology centers. So we're growing, and we're trying to wrap our arms around sharing data, but more importantly, how we access that data. So that's kind of the problem we are trying to solve. There's always a sweet spot after you implement an EMR, and it's all about security versus access, and you're trying to find that sweet spot in there where your clinicians have ease of access and quickness of access, but also I want to be able to sleep at night, and the thing that keeps me up is if one of those machines or some hard drive gets out of my organization that has PHI on it. John kind of hit on that before. You know, part of the solution is a VDI background. So you implement VDI and your data really gets pulled from your endpoints or from the hospital or from the clinician's fingers and resides back in the data center and actually sits right next to where our Epic servers and infrastructure sit. So that first part is protecting the data, but you know, we've been trying for many years to find ways to allow clinicians to access the chart quicker, and we always hear from physicians, they always tell us about how many clicks it takes to get to somewhere. We have a physician who can tell me exactly how many clicks it takes for him to log into the system, find his patient, get to the place where he wants to just put orders in, find the order set he wants to use, and you know, he can dictate that to me verbatim exactly how many it is, and he wants to know, you know, what am I doing for him to make it quicker? And that's always kind of the trade-off is, you know, you want to provide the security and you want to make sure you're protecting data, but you also want to make sure your clinicians can get to the information. And really it's all about allowing them to spend more time with their patients. So that's what we're striving for. That's kind of what, you know, the true emphasis for an EMR in the first place was to provide a place to easily document, easily get at the information, and allow the clinicians to spend more time with their patients. So I kind of alluded a little bit, we've been looking at ways to ease access. Even before we implemented Epic, we had, back in the 80s, we implemented a TDS system. So we had kind of a half-baked EMR for a long time, and we were trying to find ways for, first, physicians to get access to the information remotely, but then also provide them a way to sign into those multiple applications they have to get to without having to sign in over and over and over again. Some clinicians, depending on their specialty, have 5 or 6 applications that they need to get into every day, and all those, unfortunately, have different password structures, and they have to remember those. And then what happens really is they write that stuff down so they have their passwords in a place where somebody else could get to them. So it really kind of counteracts what you really want to do. So we started like 10 years ago looking at this. We implemented Epic in 2006, and then once that happened, we kind of paused on looking at other solutions just to get all of our hospitals up. So we're fully live with Epic at all of our institutions, and now the clinicians are looking at us to make the application more accessible and easier to use. So we looked at lots of solutions, and you know, there are good solutions for single sign-on. There's good solutions for security, but there's not a good solution for everything. And John kind of hit on it before. It's that awareness. It's not enough to be able to log into your applications easily, but you want to be able to be prompted or have the information brought up based on where you are or based on the patients you're taking care of. And as you roam your session. And I like to, the way I explain it to clinicians to kind of get them on board, I kind of say, you know, think of your badge as a way to store your session. So you tap in and then you can take your session and put it in your pocket, and no matter where you go, your session in Epic or the other applications you're using are in your pocket, and you just reach into your pocket and tap back in, and you're right where you left off. And that, you know, that is really what the clinicians are looking for. They really don't understand why you log them out or you lock them out or you time them out after a certain amount of time. You know, they say, I'm responsible for this information and I'm responsible for the patient's care. I want to be able to get into that record whenever I want. So that's kind of, you know, their goal. So we're trying to provide that, and we look for solutions to do that. So we really partnered with Aventura over, I don't know, it's been, what, John, 18 months, I think, to really kind of not only vet out what we want, but to kind of customize it to our workflow. And they've been very open to tweaking things and allowing us to access the chart based on some of our rules that we have inherently in the health system. So it's been a really collaborative partnership, and I really appreciate a lot, you know, how much time was spent making sure that we get a solution that works for us. So just a real quick, I know people don't want a techie overview, but just really quickly, this slide shows how we've implemented the solution. So on the left-hand side, the workstations, what we've really deployed right now, since we're moving rapidly from a PC-based endpoint organization to a virtual desktop organization, but we didn't want to just replace all of our computers, because we've invested a lot to, I know those in the healthcare business know the Windows 7 implementation probably took most of their time the last, you know, year and a half. So we've upgraded a lot of machines to get to the Windows 7. So I don't want to just throw those out and put thin clients or zero clients in. I want to utilize that. So what we've deployed now, and we'll transition to a zero client environment, but we've implemented thin PC. So really it's just using the current machines that we have, and that's on the left-hand side. So then the Aventura cluster kind of sits in between our Active Directory for authentication and then our VMware vSphere environment, and that's how the roaming and the awareness comes to the desktop. So the biggest impact from a caregiver perspective, and the feedback we've gotten initially, is it, you know, really decreases their time to get to the information they need. And, you know, that's the thing that, you know, when I walk the floors and talk to the nurses, they're always asking me, you know, how can I do this better? It seems like it's such a waste of time. You know, the EMR provides a single place to put all your information, and it allows 1,001 clinicians to be in that chart at the same time. So, you know, it's a giant leap from a paper world, because, you know, trying to hunt down a chart is gone. But still, documenting and getting to your patients isn't the easiest thing. There's multiple screens you have to go through, multiple clicks. And, you know, most caregivers in a med-surg environment, you know, have 5 or 6 patients out here in California with our ratios, but still that's a lot of time spent, you know, finding the patient's chart, clicking into the chart, finding where you want to document either flow sheets or order entry, and you're constantly clicking open, clicking down, and a lot of times you're accessing that same patient's chart, you're just accessing it in different locations, and you have to go through that whole iteration every single time, because the desktop requires you to log back in, and it takes you back to your patient list, and you have to start the process all over again every time you log out. So this is really kind of our depiction of our time and motion study. So, you know, everything's all ROI based when you get to a hospital, especially if you're a not-for-profit community hospital. You know, your reimbursement is so low, and your you know, your return on investment is usually 3 to 5%, and your reimbursement hovers in that area too. So anytime IT wants to implement something, you always have to fill out the ROI metrics and try to show why it's worthy of spending the upfront costs, and they all want to know where it's going to save money. And really, with the Aventura solution, it's about time back to the clinicians and about alleviating time of logging in and clicking around, and that's also the frustration point. So you can see on that slide, you know, it takes about from the desktop 21 seconds to log into Epic and get your patient's chart open, and then it takes another 10 or so seconds to find where you want to chart in that patient's record. So after VDI and Aventura, you know, it takes 8 seconds to get to your applications, and it, you know, it just might not just be Epic. It could be for our physicians, our ER physicians. They use a PAC system constantly, and they're using Dragon to do supplemental documentation in the record. So we launch those 3 applications at the same time, so that saves them all that time of logging into multiple systems. And then once you've logged in, that stays hot, right? So that session is sitting in the background waiting for them to tap into another location. So, you know, it saves a ton of time, and especially over a shift. And if you multiply that by the number of patients either the physician has to see every day, if he's a hospitalist rounding, or if it's a nurse taking care of 5 or 6 patients, you can see how that time really adds up. And it gives the nurses time back that they can spend with their patients. And, you know, not spending incidental overtime doing charting post-shift, which is really something that the nursing executives really push for. So this is kind of how the workflow works now. You know, the clinician logs in, and usually they log in, you know, if it's a nurse, they log in at the nursing station, and they're kind of getting a lay of the land and seeing what their patients need and kind of prioritizing based on clinical needs and acuity. And then if they go to the bedside or go to the WOW, they're logging in again and going back to where they just came from. But there's no way to kind of save your place. And that kind of just happens over and over, with logging in and logging out. And then, you know, based on security in our old infrastructure to protect PHI, we log clinicians out after 5 minutes of non-use. So if they walk away from a terminal that doesn't have VDI and Aventura, that session in Epic completely logs out, and they have to start all over again. So, you know, every patient, depending on the acuity and how many times they're in that chart, you can see you can log in multiple times, and that's, you know, a lot of time. And it's really, you know, we didn't capture it here on the slides, but it's really acuity based too. So if you're in an ICU and you have a patient that has, you know, sometimes 3 or 5 minute interventions, you can imagine how many times those ICU doctors or ICU nurses are logging in and getting back to that same location over and over and over again. And so, you know, as that acuity goes up, the frustration goes up as well. So, like I said, you know, the nurse cares for 4 or 5, you know, if it's an ICU, 2 patients or 1 patient, but they're really interacting with that patient 6 or 7 times during a shift, multiplying that by the 5 or 6 patients. And then, you know, usually they access the record for that same patient 3 or more times just to get a task done, just to do order entry or just to do documentation. So all that kind of going back and forth, we kind of did like I said, we did a time motion study. It's 72 to 120 logins per shift for the average nurse. So you multiply that by 1 seconds, and that's where we got that 25 to 30 minutes. And you know, if you can give a nurse 30 minutes back in her day, that's more time she can spend with the patients and not spending time after her shift documenting. So physicians are similar. When they're rounding, they're doing the same thing. They usually in our environment at Orange Coast, we have some units have physician documentation rooms, so physicians kind of go there, log in, kind of organize their day, look at their patients, and kind of see who they need to see first. And then they'll go out onto the unit and log in either at a WOW or at the nursing station where the patient's located. And they're doing the same thing the nurses are doing. It's a constant logging in, logging out, logging back in, and going to the same place they just left. But it's just they're in a different location. So they don't generally have as many logins because the doctors do rounds in the morning or in the afternoon. But they're our hospitalists average 10 or more patients that they have to see. And so you can multiply how much time that they're spending. And then the physicians have the added burden of having multiple applications. Nurses are generally just accessing Epic and their email. But the physicians, like I said earlier, they're accessing PACS, they're accessing, if they're using Dragon, they're accessing Dragon. And there's some specific workflows, like in cardiology, where they're accessing a Single Dynamics or a Philips a workstation, and they're going through logging into Epic, putting that aside, logging into the specific application for their discipline. So that adds to their frustration also. So with roaming desktops, nurses really save time because once you've pulled up your patient, like I said, I kind of use that analogy where you take that session and you stick it in your pocket, and no matter where you go right back to where you left off. That really adds value because, going through a chart, even an electronic chart, you're still going to multiple pages and clicking in and clicking out of things. And, it's, John hit on it earlier, it's aware. So if you're in a hospital and you have a desktop dedicated to one room or two rooms, you can really log in a nursing workstation, then tap out, go to the patient's room, and if you're in patient A's room and you tap in, it's going to pull patient A's record up for you, so you're not having to click out and click back into that record. And like I said, the docs save time in similar ways, and it's just multiplied by their applications. Yeah, doctors and nurses really hate mindless tasks. You hear from physicians, and we still hear it. We implemented our first Epic install in 2006, and those same doctors tell us, I'm not a ward clerk, and I don't understand why I have to click a mouse 100 times a day. It just doesn't make sense. They didn't go to. You always hear they didn't go to medical school to be a ward clerk or be someone who clicks a mouse all day. They're there to take care of patients. So anything we can do to allow them to take care of their patients and alleviate that frustration, and it's that sweet spot again. It's getting them ease of access, but still allowing us on the IT side to feel secure that the desktop and the patient information is secure. So the nice thing about awareness, go back one please, is that based on who you are and where you are, Aventura really allows that workflow to know who you are, where you are, and really kind of what patient you're taking care of. Also, it can tell you, it can log in, like Dragon is a great example. It can pull up Dragon and roam your session and roam. It's basically leaving the cursor where you left off in that note, and the doctor can just pick up the mic and continue. So what we did from a planning perspective, like John alluded to before, it really is sits on a virtual desktop environment. So just the planning around that, it's a real mindset shift from a kind of a desktop or PC world to a virtual desktop world, and just all the planning around that. And people think that you can, just trade that off very simply, but there's a lot of planning that has to go into effect, and you got to kind of decide from a governance standpoint, how are we going to allow access? How much security are we going to put on there? An example of that is, you can tap in and provide your credentials, so that's that dual authentication that John talked about. But how long do you allow them to work without authenticating again? Do you make them authenticate every time? Is that going to add frustration, or do you allow them half of their shift or the full shift? So that's kind of things that you have to consider and what we considered. The other big thing, just like with an EMR, you have to have an executive sponsor and a clinical champion. So you really need nurse and physician champions, and they really have to be the ones that come into the lab and really hit on the system when you're doing a proof of concept, and they have to be the key people when you do a pilot. You have to kind of find the workflow or the environment that would be open to trying new things. We did our pilot in the ER, and people kind of think, oh, that's crazy. That's like ground zero for most hospitals and where all the action is. But that's where the biggest bang for your buck is. They're the ones that are accessing multiple devices in multiple areas on multiple patients. So the benefits are highest in those high acuity and fast-moving environments like an ICU or an ER. So we wanted to create, that sweet. We wanted to find that sweet spot. So creating the compromise between, how much accessibility you give them, but also my CIO needs to be able to sleep well at night knowing that all that information is secure and has no way to get out. So just putting VDI in adds that security, but it doesn't really help on the accessibility part. So I really think that an Aventura product really solves that and really gets you into that kind of sweet spot. So I think we're open for Q&A.
Yep, thanks, Scott. We'd like to open it up for questions to the audience, and as a reminder, use the questions section on the GoToWebinar panel to submit your questions to John and Scott. Our first question is for you, Scott. You mentioned SSOs weren't worth the investment. In your findings, how did they not solve the full problem for MemorialCare?
Yeah, so just giving a single sign-on solution, so that does help you in that initial logon, but it really doesn't kind of save your place with the application. So kind of early systems, you could log in and through AD credentials you could launch those applications, but you're launching those applications, with virtual desktop environment and Aventura, that stuff is kind of hot and running in the background, so the next time you tap in, it's right at your fingertips. It's not going through the whole iteration of just pulling up applications. And in a traditional PC environment, it would help in some areas, but when we first looked at it, the cost of it and what you got out of it from an organization standpoint, it just wasn't worth it, and it didn't get support. And some of it, especially the early systems, were very clunky on how you registered and put your credentials in for those applications. So it just, we did a pilot. We had some key clinicians and physicians using it, and they just said it's not really worth it. It's not giving them the value that they wanted.
Okay, good. John, the next question is for you. You went through a few hospital results. What, in your opinion, is the biggest impact you see awareness computing bringing to hospitals?
Well, thanks. My first inclination is when I talk to customers, the word speed always comes up. It's just getting there faster. Like Scott said, carrying your desktop in your pocket and just having it accessible whenever you want. I think Scott actually had a slide on this about impact, and it was really about time, speed equating to time, and giving back. I'm paraphrasing Scott's words better than mine. Giving time back to the doctors to spend with their patients. So that's we hear a lot of nice things, but that's the one that comes up almost every conversation. So I'd probably say that's what I would call the biggest impact.
Okay. You mentioned piloting in the ED. Do you have plans to extend to the rest of the hospital, or have you already, perhaps?
We do have plans to extend it. You know, we feel that the ER is really, I mean, it's high stakes. Generally, people don't pilot there, but like I said, it's where you get the greatest value out of having applications and EMR sessions hot and ready to be accessed. And you know, we from a security standpoint, you know, we're all going to go down this. Well, I feel, at least my opinion, we're all going to go down a dual authentication highway, and so you know, there's certain areas where they're only accessing the EMR itself, but even in those areas, they may be accessing their email. So it's kind of twofold for us. We want to add the security, that the badging and the dual authentication, and we're changing our environment to a VDI environment. So as we roll out VDI to other areas, we're gonna roll out Aventura along with it. So our plan is to start in the high impact areas and then migrate out to other areas. And you know, I mentioned earlier that MemorialCare is really looking at the full patient care continuum, and we've invested in those ambulatory sites, and we have a broad base of physicians that are running our ambulatory EMR of Epic, and I see this product going out into those areas as well. You know, the virtualization from providing a virtual desktop alleviates their concern of having their PHI on desktops, and it also, you know, if you think about a physician practice, multiple caregivers are accessing a patient's chart in those rooms, and be able to have those sessions open and ready to document in as you just go from room to room and see patient to patient. There's a lot of value in taking it out into the ambulatory space as well.
Great, thanks, Scott. That was our last question, so with that, we'll conclude the webinar. I want to thank everyone for joining us today, and thank you, John and Scott, for an informative presentation. I want to remind the attendees to watch your email for links to the recording of today's webinar, as well as the PDF version of the PowerPoint presentation. I hope everybody has a great rest of the day, and we look forward to seeing you at our next HIStalk webinar.